Okay. Um, Hi, my name is John Wiener. I'm a pediatric urologist at Duke University, and I'm going to be talking about long-term outcomes after hypospadias repair. I just left the operating room after about 7 hours on a very complex hypospadias repair with one of my partner, John Ruth. You can probably still see the line on my head from the scrub cap. I have no disclosures, and I really become interested in this topic as I'm taking the long view of hypospadias. I looked at this syllabus, and I know you're going to be having lectures on a lot of how to do hypospadias, and there's no shortage of people who talk about how to do hypospadias repairs. I've been doing this long enough that I want to share some of my thoughts and some of the research I've done, more research of other people's studies. So 23 years ago this year, I joined the faculty at Duke after my fellowship in Houston. No gray hair. I joined Lowell King, who was the first American to be a full-time pediatric urologist. He'd spent the first half of his career in Chicago and then came to Duke. Really one of the giants in the field. Then right before COVID hit, my wife and I took a trip to Asia. You can see I've developed a little gray hair over the last 23 years. So you're getting to talk from an old man who's developed a lot of gray hair, taking care of complications. So to quote my friend Larry Baskin, that really had set this lecture up before I even knew about the PedsUroFLO from UCSF, so this is total coincidence. But Larry talks about that there are varsity cases and there are junior varsity cases. Obviously, the one I just left was a varsity case. Here at Duke, our varsity plays a little basketball. This was the last national championship team in 2015. But as a basketball coach, this is more this kind of a coach. Clearly, there are variations in phenotypes of hypospadias. Here's a glandular case that just needs to do a little glanduloplasty there. A coronal case, which is pretty typical, and another coronal case in a teenager. And then there are more the varsity cases. It doesn't look very far from the meatus to the sulcus in the glands, but you can see there's severe chordee, like 90 degrees, and so when that straightens out, this is obviously going to be penis-scrotal. This is the case I just left was the second stage in this kid. This kid has a inborn error of steroidogenesis defect, and so this is about as bad as hypospadias gets. In fact, we spent the first part of the case laparoscopically working on his vaginal remnant. So I'm going to go over a little history. I like history, and I think it's important, particularly for people in fellowship, to know where we came from, because life isn't as bad as it used to be. So we talk about proximal hypospadias. I'm going to present a case who became my patient in 1997 at age 22. So he was born in 75. His repair was likely done with scrotal skin. They did a lot of that back in the 60s and 70s. There's a lot of scrotal skin there. But we found that it has problems, that it grows hair at puberty. And so people have hair coming out of their urethra. They get stones on that hair. And it just isn't very waterproof and didn't hold up well. So I met him in 97. And at that point, he'd already had 20 operations. So I think it's great that we don't see these patients today that have had dozens of operations, but that was pretty typical back in the day. So I look back at a clinic note from 2000, and so I say return to his first visit in almost 1 year. He has a weak stream and must void for almost 1 minute. He must milk his diverticulum to empty his urethra. He has normal sexual activity but has burning for several days afterwards. And he's very frustrated by his persistent problems and desires formal urethroplasty. This is a retrograde urethrogram And you can see he's got this narrow urethra and the pendulous urethra, and then the bulbar urethra is this big diverticulum going up to the sphincter. And in fact, in the CPT book, you know, there's this, it's called Hypospadias cripple. This was a fairly common problem back in the day. We don't use the term Hypospadias cripple much anymore. We rarely use this code, fortunately, but it's a real thing. He had 9 subsequent operations. I went into Care Everywhere, which is the in Epic, just to look him up when I was making this lecture. And I found that he'd had a urethroplasty with buccal mucosal graft in 2016 at another academic medical center in our state. It said he had 1 post-op UTI, and he was on methadone for chronic pelvic, penile, and testicular pain, and admitted to the MICU for Xanax overdose. So there's a lot of emotional and psychological issues with hypospadias repair. I hope that none of you ever have to encounter patients that have two or three dozen operations. More recent past, so these twins were born here in Durham. Their parents were good friends of my wife and mine. And they were told that they were going to have baby girls. They were born. They put pink balloons on the mailbox. And then a few hours later, a pediatrician made rounds and said, I don't think these are girls. I think they're boys with hypospadias. They had a negative DSD workup, but they probably have partial androgen insensitivity. They were referred to me, and they both had penis-scrotal hypospadias with chordee and micropenis. I chose to give them 4 doses of pre-op testosterone. Twin A did not respond as well as his brother. They both underwent a first-stage repair. Actually, I was young and stupid in those days and did them both the same day, one after the other. And then 6 months later, did the same thing with the second stage. Twin A required a fistula repair at 6 months. But at age 5, I really had one of the highlights of my career. Again, I'm good friends with the parents. And I went to a Carolinas hockey game, Carolina Hurricanes hockey game with them. And all 3 of us were standing at urinals. I was in the middle, and each of them were urinating next to me standing up. So really gratifying as a pediatric urologist to see that. Not an actual picture, just taken off the web. So at age 7, Twin A noticed that his penis was smaller than his brother's. Both required an orchidopexy for a right ascended testis. Both had it on the right side. At age 12, they were both Tanner stage 3. Twin A definitely had a smaller penis. They both could void standing with mild post-void dribbling, and they had straight erections. Twin B had 2 UTIs with some LUTs, got a flow rate on him, and you can see it's sort of a plateau with a maximum flow of 8 down here. Age 13, he had no more UTIs. His LUTs improved spontaneously. I saw him recently, and he had a good sized penis, about 10 to 11 centimeters, mild chordee, and both testes were normal adult size. His brother at age 12 had little LUTs, but he had a little post-void dribbling. His flow rate, pretty good, flow rate of 13. It's still a little bit of a plateau. And at age 13, his right testis was atrophic and his left testicle was small and soft. At age 16, his penis was about 8 centimeters, kind of at the lower limit of normal, 8 or 9 centimeters. His testosterone was normal, but his FSH and LH were elevated. And we talked about fertility, and he gave a semen sample and was azospermic. I don't think that had anything to do with the hypospadias repair, because I think it's a global endocrinopathy. So obviously a lot of frustration for him, and a lot of psychological issues. And as a surgeon, particularly children of parents of people I know, as a surgeon, we go through this self-doubt. You know, am I a bad surgeon? Am I harming children? Am I recreating lifelong misery? But I think one cannot know without studying one's own outcomes and those of others, and that's what kind of led me to make this talk. So here in the 20th century, this is what I was taught. Currently, an expected complication rate of 5 to 10%, mostly fistulas, exists for one-stage hypospadias surgery. This was John Duckett's chapter in Campbell's. And John Duckett was the giant in pediatric urology when I was starting fellowship. He died at 97, just a few months before I finished my fellowship. But he was the man, and he thought all hypospadias repairs should be a single stage, and that I saw him berate someone who suggested that they should be done in 2 stages. But Dr. Duckett, who will be spinning in his grave with the data I'm presenting. In the 21st century, you know, as I said, we're no longer seeing hypospadias cripples who've had dozens of operations. We see a lot fewer diverticula, hair-bearing urethras, and urethral stones. But really, what should we expect realistically? So these are 2 studies here, and they're more realistic and they have longer-term data than what Dr. Duckett was writing about. So Dr. Duckett was at CHOP his entire career. And so he would turn over his grave knowing that they were doing stage repairs of proximal hypospadias. And this is a 8-year period here, led by Chris Long, who's really doing a lot of their hypospadias work. David Chu is one of my former residents. So they are additional operations besides the 2-stage in 56% with a mean follow-up of less than 3 years. So that's a over 50% complication rate. And it could be 1 stage with 62% or 2 stage 49%. Texas Children's Hospital, where I trained with Dr. Gonzalez, what was their outcome? Additional operations in 68%. And similar follow-up. So, you know, when I was starting out, and then I was quoting Dr. Duckett saying, oh, there's like a 10% chance you'll need another operation. Now we can say, look, we're going to do stage operation, but there's over 50% chances there's going to be a 3rd operation. And what about patient-reported outcomes? Most of the literature is just surgeon-reported outcomes. So what about the voiding symptoms, penile length, chordee and erectile dysfunction, and self-esteem and sexual function? So the goals of hypospadias repair should be pretty clear to all of us. This is a print famous from a French restaurant. My grandfather gave this to my father, who did a lot of pediatric urology in Mississippi way back when. So our goals are have a satisfactory urinary stream, hopefully standing, with minimal to no LUTs, a penis of sufficient straightness with a distal meatus for satisfactory sexual function and fertility, and satisfactory self-esteem about their penile appearance. So what can we expect? This is a nice study from the group in Belgium. It is a single institution series, as all the ones I'm going to be talking about. But they looked at 474 primary repairs over a 13-year, 14-year period. And pretty typical that over 3/4 are distal, some penile shaft, and 10 to 15% proximals. 40% were tuberous incised plate, meatal advancement, and 36%, which scares me a little bit. I don't think that meatal advancement is that useful if you're, unless it's really glandular. And an onlay procedure using interperputial skin. A little different in this country, mean age of primary repair at 22 months, a little bit later than standard in the US. So mean follow-up after primary repair was 34 months, but up to 12 years. Single procedure in 76%. And the reasons for repeat operation were fistula in 11%, of course, the most common complication, meatal stenosis in 7%, and cosmesis in 7%. Other in 3%. And so this is the percentage of patients not undergoing a repeat operation. You can see here in the first 4 or 5 years it drops and then it starts plateauing out. Obviously the proximals are a lot different than the distal or midshaft. So 79% of the distal and midshaft did not need a second operation, whereas only 53% of the proximals did not need a second operation. Just a little bit from our work. My two partners, when I finally got partners, John Ruth, who's with me currently, and Sherry Ross, who's now at UNC, we were looking at our is caudal affecting outcomes, and I won't get into that argument. But from my own data, it's a little scary because these two young faculty members said, "Hey, let's look at your hypospadias repairs." So that's a little bit humbling. They looked at 395 of my patients over 15 years, and again, similar, a little over 80% distal, some midshaft, and same as in Belgium, 11% proximal, mean age a little younger. And outcome in fistula, fistula or glans dehiscence in 6%, distal was only 3%, and proximal were 11. These were not the stage repairs, they were excluded. So fairly similar. Back to the Belgian study, those with multiple repeat operations, the distal only were 4%, midshaft 6%, but more repeat operations in the proximals. And what about the timing? Well, the reoperation the first year, of those who needed reoperation, it was almost half. Only 15% were in the second year, and those needing reoperation after the second year were 38%. The mean time to reoperation was about 25 months with a median of 14. And after 3 years, only 1 in 14.8 would need a reoperation. So usually after 3 years, you're usually in the clear, but we'll talk about that. So time to first reoperation, you can see it starts plateauing around 4 or 5 years, but it's not just at 6 months like I was taught. When they did univariate analysis of significant factors, on univariate analysis, the type of suture mattered, whether they had proximal hypospadias increased the risk of reoperation, younger age at the first operation, anything other than meatal advancement, obviously more complicated surgery, and on multivariate logistic regression model, really only proximal hypospadias predicted the need for reoperation. Looking at back to my series, on univariate analysis, proximal hypospadias, of course, caudal anesthetic, it's controversial. Some studies show it does, some doesn't. We're not going to get into that argument tonight. The surgery lasted longer than 150 minutes. And interestingly, in the first half of the series, there was a greater risk of reoperation than if you were in the second half. As you'll find, you'll get better as you get older. And I certainly did, that proved it. On multivariate logistic regression, only proximal hypospadias, which was a 6-fold increase in odds ratio. Caudal anesthetic was 13. Again, I'm not going to get into that argument tonight, but proximal obviously increases the risk. So let's shift gears here a little bit. And let's do an in-depth look at long-term outcomes. And obviously the complications we're talking about are urethral-cutaneous fistula, a weak stream or obstruction, testicular ascent, penile appearance, sexual outcomes, and psychological outcomes. There's not a lot written about this, and I'm going to review basically all the papers that have been written on it. They're just not that many. And of course, it's going to be slanted toward the more proximal cases. So in terms of urinary stream, well, fistula is the most common complication. Occurrence is closely related to the degree of hypospadias. Obviously, the longer your repair, the greater the risk of a fistula. Most occur in the first year after surgery. Hadley Wood, who's a big transition urologist, and I work with some on transition issues. When she was a resident at the Cleveland Clinic, they published this paper 12 years ago, and 23% presented more than 2 years after surgery. And to reach the 90 or 99th detection rate, you had to go 8 and 20 years later. So some occur later. I was doing a fistula repair on a teenager, and our resident, Galib Jabari, said, "That doesn't happen." I said, "Well, it does. We see it." He said, "Well, let's look at your series." And first off, there's now Ashley Johnston, who just matched for fellowship in Indiana. So looking at the Duke experience, not just mine, but of 151 fistula repairs, 12 or 8% presented more than 5 years after repair. Of these, the mean was 11.5 years, 7 to 15 years, almost 16 years. 4 had their initial repair elsewhere, and nearly 60% were initially distal repairs. So they can occur late. Weak stream. If you read the literature, it occurs in some wide range here from 7 to 70% of cases, depending what you read. And this is really our most feared complication as a stricture stenosis, and that can present with LUTS, a diverticulum, fistulae, UTIs, and what we really don't want to see is irreversible bladder or upper tract changes from high voiding pressures. So this is an interesting study published a couple of years ago. Is a weak stream present prior to repair? Does hypospadias cause a weak stream even if it's not repaired? This is a study of just 26 boys undergoing primary repair in New Delhi. And being in New Delhi, the age was a lot older than you'd see in Western countries with a mean age of 6. And 14, or over half, had obstructive flow patterns with a flow rate less than the 5th percentile before having hypospadias repair. It's always been a question of mine because a lot of times you'll see these kids and they'll have a tiny meatus. But what about after repair? Same series. So the 3-month post-op flow rates, 69%, up from 54%, had an obstructive flow pattern. Of the 14 abnormal pre-op, 10 were still obstructive but improved. 1 was equivocal, and 3 were now normal with a flow rate over the 25th percentile. Of 12 that were normal pre-op, 9 were normal, but 3 were obstructive. And that's kind of what we worry about. Are we creating obstruction? And does it improve with time after repair? Same study, 3 months post-op, the flow rates now 31% were normal. 6 months, 30% were normal, but 3 of the 4 that had obstructive rates at 3 months were now normal. And at 9 months, it just had 4, I only had 7 patients, but 57% were normal and they were all improved. Obviously, there's some selection bias here. I'm going to mention a lot of studies from Sweden. Maria Andersson has worked with Dr. Holmdahl, and she's a PhD who did a lot of research in the long-term outcomes of hypospadias. So there are a bunch of papers that she wrote. It was her doctoral thesis. And really great work that you couldn't do in this country because we just don't have the long-term follow-up because we don't have a good national healthcare system, but Sweden does, and these are wonderful papers. So does this weak stream improve with time after repair? Well, the 126 boys undergoing a TIP repair, 48 had flow rates at 1 and 7 years postoperatively. 11 had intervention for obstructive symptoms, so almost 10%, and there were 37 others for analysis. Again, not just a minority of the cases, but this is the best that's in the literature. So you can see here, this is 1 year postoperatively, and you can see there are a fair number here under the 5th percentile, and you can also see there's more red for the proximal cases. Now, 7 years postoperatively, fewer cases in this below 5th percentile, and some over the 95th percentile. So it looks like things improve. At 1 year, the mean flow rate was 13.6, with 49% below the 5th percentile. So 49% were abnormal. At 7 years, the mean flow rate was 19, with only 32% below the 5th percentile. So looks like things might improve with time. All that were below the 5th percentile at 1 year were improved, with 28% now above the 25th percentile. This was more common with proximal hypospadias repairs. How about, does it improve with time after puberty? So not a lot of penile growth between age 3 and puberty, but what happens when it grows at puberty? And I can tell you, this is something we didn't know until these papers came out a few years ago. So same cohort of boys, and 40 had flow rates at 2 months, 12 months, 7 years, and puberty. meaning ages 13 to 17. We had 31 distals and 9 midshaft hypospadias, so no proximals. So in terms of those that had a normal flow rate over 25% at 12 months post-op, only 37.5. At 7 years, not much different, 40%. But at puberty, 95% had normal flow rates. Of the 40, 5 had had a meatotomy for obstructive symptoms, and 4 had had urethral dilation. And just looking at the pictures, abnormal being a flow rate is in the 5 to 10 percentile. You can see it's a majority there in the first year after surgery. 7 years, not much different. But look here after puberty, very small number, most having median type flow rates. So now, that's great, but can we reproduce this elsewhere? Well, these are studies from Montreal with Anna-Marie Bull's group. And similar findings, 153 boys with distal hypospadias. These are the distal repairs, tips, matus, or flip-flops, and magpies with more than 10 years of follow-up. Obstructive flow rates, less than the 5th percentile, 60% of the 2 to 7-year-olds, but after 13, only 10%. No difference between types of surgery, but the sample sizes were small. But again, you can see here that flow rates improve with time, which is heartening to see, that as the penis grows, that urethra is not a fixed scar. It's going to grow and allow better flow rates. A follow-up paper the following year in 52 boys with proximal hypospadias, and this was a tip, an onlay, or the ducket transverse island tubularized with 12 years of follow-up. And again, seeing the same thing, those less than 25th percentile, 3 to 7 years, 83%, 7 to 13 years, 65%, but it drops to 20% at 13 years. Similar kind of curves there, regardless of the type of procedure. Let's go to Australia with John Hudson's group. How does this compare to normal boys? They had 21 controls that were aged 13 to 16, and they recruited boys after hypospadias repair who were 13 to 15. Their series of 383 patients, they got 60 back. This is the flaw of all these studies. There's just not universal follow-up. And 88 of the cases, their flow rate was less than the mean of the normal nomogram from the normal controls. And 14% were less than 2 standard deviations below normal, which would be less than 5%. And those, it was found it was not associated with the original meatal position, age at the first surgery, need for additional operations, complications, or current anatomy. Here's their, the normals here in blue and the cases here in red. And you can see that they're kind of all over the place. But the flow rates are not as good as in the controls, but you can see that they close the gap with they found that the poor flow rate was associated with moderate or severe chordee, obviously worse cases. Those, they had significant post-void residuals, more likely to have post-void dribbling. Flow patterns were really not statistically significantly different. They were bell-shaped in 70% of the cases versus nearly 70% of the controls, but a plateau type of flow pattern in 20% of the cases versus 6% of the controls. So in conclusion, flow rates do improve in most with growth, but it may never be normal. And so for that reason, you shouldn't intervene unless the patient is symptomatic. Flow rates are good, they're important, but these studies from 3 different continents are really critical in teaching us over the last 5 to 10 years that flow rates do get better with age. So don't operate just because of the flow rate. Reoperate if they're having symptoms. Long-term follow-up with a flow rate is suggested. And of course, long-term follow-up is also supported by the urethral-cutaneous fistula data that I presented from Cleveland and from our center. A lot of the proximal cases are going to have post-void dribbling, even without stenosis or stricture, because that urethra is just not as elastic, so it expands when they urinate, but it doesn't snap back and push all the urine out as the stream ends, and so they often trap a little urine. What about testicular ascent? This is something I knew nothing about. And I had experienced in a few patients, like those twins I talked about at the beginning. Really only seen this one study from Japan, and 466 boys with hypospadias, 6% had congenital cryptorchidism, like that boy I operated on today with the perineal hypospadias. That's pretty clear cut, but nobody really talks about acquired cryptorchidism or extended testes. That wasn't even a thing until the 1990s. I wasn't taught about that as a resident or fellow. But some are going to have ascended testes. They're just not well fixed. And the incidence of both of these were higher with proximal cases. So lesson is, don't forget to examine the scrotum. Even in your proximal cases who you're following up in long term, you kind of focus on the penis and you forget to look at the testicles. So when they come back, you got to look at the testicles and palpate them. What about long-term chordee outcomes? These are two different studies from the Swedish groups. And this is 126 adolescents with corrected hypospadias after a tip repair. And the clinician's notes state that 86% had straight penises and only 14% had glandular tilt, so no true chordee. But when they asked the patients, 75% were straight, but 9 had slight downward curvature and 15% said they were significantly deviated. So as we're learning here, and this is, again, this was thesis work from Maria Anderson, but patient-reported outcomes are important. Particularly what we see in clinic may not be what's happening at home. So they looked at 167 men with corrected hypospadias and compared them to 169 controls. Of curvature of 0 to either no chordee or 10% or less, of the cases, 75% had essentially straight penises versus 98% of the controls. 10 to 30%, 23% of the cases versus 2% of the controls. So these are men who had basically distal hypospadias corrected, but almost a quarter have 10 to 30% chordee as adults. What about penile appearance? Same adolescent study. Meatal position was only at the tip of the glands in 13%, ventral glands in 74%. I don't know their type of repair, but if you do a lot of meatal advancements, I don't think you're going to get the meatus out to the tip. At the corona in 13%. So only 13% are really where we're aiming to get it at. In terms of meatal shape, atypical or rounded, not a nice slit, in about 33%. This is the Swedish adult study where Anderson was not the lead author. This is great data. I've not seen this anywhere else. Love this, this picture here. So this is penile length. And if you look at the controls and distal, so the black and the rust color here, they're the same at 11 centimeters. If you look at the mid-shafts, hypospadias, 10 centimeters. A little different, a little slightly less, but not a big difference. But look at the distals. So, I'm sorry, look at the proximals, 7 centimeters, statistically significantly different. This is really meaningful data. We can do a great hypospadias repair, but we cannot make the penis longer. And it's tough when you talk to these kids. I had an 18-year-old who I repaired back in 2002 in the office yesterday. And you know, these are tough man-to-man conversations about your penis is not going to be as long. But I'm going to show you some data that makes me feel better. The circumference is less in the cases versus the controls. The width isn't different, so the penises have the same width, but they tend to be more sort of oval than round. The glands length and corona to meatus distance is shorter. The glands are just not as big in these cases. And the penile perception score correlated with the degree of hypospadias and the penile length. What about sexual outcomes? Again, from Sweden, there was no difference in gland sensation orgasmic function or penile pain between the cases and controls. There was erectile dysfunction in 10% of the proximal cases. I think this is one of the things that we transitional urologists are finding, is that these repairs we do may not be, we may have some that are going to have affected erectile function. And ejaculation in 11%. That's obviously pretty worrisome. There was no difference in sexual or gender orientation. There was no difference in engaging in sexual activity. No difference in the mean age of sexual debut. So these are 167 cases versus 216 controls at a mean age of 33. This is a different paper, but the same authors. No difference in partnering. The proximal hypospadias cases had less partnering, but it was not statistically significant. The proximal hypospadias repairs had fewer children, lower reported fertility, but reported fertility issues were rare. There was no difference in the extent of intercourse or the age of sexarchy. Never heard that word before, but it was the same for cases and controls at around 18 years. There was some decreased sensitivity in the, with greater degree of hypospadias. But again, as someone who's been doing hypospadias repairs for over 20 years and seeing some of these, this makes me feel better. And I can tell parents and I can tell the teenagers that, you know, you're going to be able to have sex. The sexual life satisfaction scores were similar. That's really heartening data. The odds were lower in the proximal cases, and the odds of satisfaction were higher if they were in a relationship or had a higher penile perception score within the mid or proximal hypospadias men. So some of this may be psychological if they're in a good situation and feel better about their penis. And interestingly, it didn't correlate with the penile length. So again, that's very helpful for me when I'm seeing a 16 or 18-year-old who has an 8-centimeter penis saying, yeah, it's going to be smaller, but we find that men still have good sex lives. What about the psychological outcomes? Again, this is just great work they did in Sweden. There was no difference in body image or psychological well-being. Again, very heartening for somebody who's been doing hypospadias repair for a long time. There's no difference in educational level attained. The proximal hypospadias patients had more tutoring, but they reached the same educational level. So these people aren't dropouts. Proximal hypospadias repair patients were more interested in having more frequent follow-up. So again, the patients are telling us they do want to come and talk to us about these things. And again, this data that the Swedes are teaching us is really helpful. Has anyone else done this kind of work? Here's a study from a couple of years ago from the Netherlands in Utrecht. And this was adult men who had hypospadias repairs, 87 to 93. It was 54 of the 121 eligible. There were 12 tubularized transverse island flaps, that's the ducat repair, and 42 distals. Complication rates were high regardless, 75%, but 62% of the distals. There was no difference in their IPSS scores in terms of voiding. The Qmax was a little bit higher in the distal repairs as you'd expect, but these weren't statistically significant. But the proximal repairs had more with a plateau pattern. The proximal group had a shorter penile length, 10 versus almost 13 centimeters. So these are measuring a little longer than in Sweden. But again, I don't know that they have bigger penises in the Netherlands. A lot of it depends on how far you push down on the suprapubic fat when you do a stretch length. There was no difference in penile perception scores or body image, but there was some decreased satisfaction with the penile appearance and length in the proximal cases. Those having no curvature or torsion, this is a little sobering. Only 18% of the proximal cases said that, and just over half of the distal repairs said they had no curvature or torsion. Torsion of less than 50% or curvature in the 30 to 50 degree range. Again, here you're talking about 82% of the proximals and almost half of the distals. There was no difference in the IEF scores about erections, except in orgasmic function, and there was fewer with strong ejaculation in the proximal hypospadias repairs. Again, these patients probably have a global endocrinopathy, but also that urethra is not as elastic and they doesn't have the ischiocavernosus and bulbocavernosus muscles to propel that semen. So not surprising they have more ejaculatory dysfunction. The proximal hypospadias repairs had a later age at first kiss and fewer had intercourse, but again, the similar age for the first intercourse at 16 to 17 years. Sexual and psychological outcomes. So in conclusion, I think most do quite well, even the proximal cases. I think this data is very reassuring to me. I certainly have my moments of self-doubt when I see some of these teenagers, but I'm feeling better reading these papers, but realize that not all will do well. We really need long-term follow-up, particularly in the proximal cases. We need more long-term studies. You young people, when you get out, start setting up long-term databases. Follow-ups, most of the studies aren't like the ones I quoted here. Most only give 6 or 12-month results. And so I think you have to question anything about some new hypospadias repair with short-term results. In terms of follow-up, we do need to balance missing rare complications with bringing attention. Some of the distal repairs, particularly the glandular hypospadias, like a magpie, really shouldn't get stenosis or fistula because you really haven't done a urethroplasty. So they're probably not at risk for complications. And do you want to bring all those kids back at puberty saying, hey, you had an abnormal penis when you were a kid? So you have to balance that. So for distal repairs, there's really no agreement about follow-up, but I think the proximal repairs, everybody agrees that there's a need for follow-up after toilet training so that you get some information about their stream, where the parents can watch the stream and you can get a flow rate, and also during puberty after penile growth. I think you should get flow rates, but again, interpret with caution. Somebody who has a poor flow rate, you just need to follow those patients more carefully, maybe more often, but you don't need to intervene if the only symptom is a low flow rate. And then again, probably might need to follow them not just into puberty, but beyond puberty, as that study showed that a lot of the patients wanted more follow-up. I'll leave you with this great quote from a great name. This was one of the early pediatric urologists in London. What a great name, Twisington Higgins. Hypospadias is a grievous deformity which must ever move us to the highest endeavor. The refashioning of the urethra offers a problem as formidable as any in our art. The fruits of success are beyond rubies. The gratitude of a boy has to be experienced to be believed. 80 years later, I still say there's no higher honor than someone allowing you to operate on their son's penis. But also there's no profession or operation that's more humbling. You can't hide your mistakes. You can't hide your complications. If you're a general surgeon and there's a problem with the common bile duct, nobody can look at that. Or you get a ureteral stricture after an ileal conduit. But the penis, it's there for everybody to see, and the parents are looking at it 10 times a day when they change the diaper. I'd also say don't believe everything presented at meetings. Again, you need to have long-term follow-up. I've seen a lot of fads come and go, so be skeptical. Be open to new things, but be skeptical. I think hypospadias, like Twisington said, pushes us to be the best physician and surgeon possible. You need to be empathetic with the patient, particularly the teenagers, and with the parents. You need to listen because different people perceive their penile differences different. This is a follow-up of twin B of those twins. I got an email from his mother last year. After I talked to him, he thought things were really abnormal, and this is from her email. He walked out of your office and stated he felt as if a huge weight was off his shoulders. I truly appreciate your listening and responding to him. So the other thing is never stop improving. Again, I was just in that case doing the second stage on that perineal hypospadias for the last 3 years. I've been doing these with my partners. I think it makes me better. We're coming up with better ways to do things. So never stop improving throughout your career. Review your outcomes and compare them to others. So with that, I will leave you. Dr. Wiener signing out here. And please take this survey. All right. Now I'm going to go to look at some questions here. Let's see. I'm going to stop sharing, and I'm going to look for the Q&A. All right. Knowing the poor outcomes for proximal hypospadias repair requiring two-stage repairs, how often do you counsel families about his potential complication rate? Well, and some of that is gained with knowledge as you know, there are patients that you think have coronal hypospadias, but when they have a really thin urethra, you realize there's really no useful urethra in the entire penile shaft. And so you'll learn, I learned the hard way that some of these that I thought were coronal were worse. But for the most part, most cases are distal, and you tell parents we're going to do this as one stage. And you know, from reviewing my data, I could tell parents if this is coronal, there's about a 6% chance you're going to need a second operation. I think one-stage repairs, proximal repairs, is not common these days. There are some that don't have much chordee, and so, but if they have a lot of chordee, it is going to take a two-stage repair. And even some of those with without a lot of chordee, and you could do with a Baskin dorsal plication, they still sometimes do better with a two-stage repair. But again, I quote those data, those papers from CHOP and from Texas Children's saying, even at the top centers in the country, over 50% of the two-stage repairs are going to need additional repairs. So don't be surprised. In fact, I kind of say, the odds are they're going to need a third repair. That's what the data show us. That data wasn't there when I was a fellow or early attending, when the studies only went to 6 to 12 months. Second question, do you give different rates for proximal hypospadias that is able to be repaired in one stage? Yeah, I mean, again, like I said at the beginning, they're varsity cases and they're junior varsity. And if the patient has a good sized penis and not much chordee, then you could do it in one stage. You know, if the urethral plate is better quality and wider, you're just going to have better outcomes. As one of my partners says, you know, it's what the patient brings to the table. So I think you can have a pretty good idea by really critically assessing the urethral plate when you're in clinic. Obviously, you can't assess it as well when you get to until you get to the operating room and get the kid asleep and put on your magnifying loops. And you know, but I basically think out loud to the parents saying, you know, the penis has good size, but the urethral plate looks narrow. So there's some factors that look good that makes us I think we're gonna be able to do this in one stage, or we're gonna have really good results, or I say, you know, this is gonna be challenging. And this is why it's challenging. There's a lot of chordee, or the urethral plate is really poor. So I think you just have to be honest and create realistic expectations. And again, we didn't do that back in the day because we didn't have this kind of data that I shared with you today. Question, do you make cystostomies? Which cases? So I've never done put in a suprapubic tube. So I would say I don't do them at all. That was very common back before my training, I think in the 70s and 80s, but by the 90s, that fell out of favor in most places, at least in the United States. You know, the proximal cases on the second stage, I may leave the catheter in for 2 weeks. I don't use a Foley. I use a straight catheter that's very soft and flexible. I like the Kindle catheter. It's a white one. It's 6 French, very soft. And I sew it to the glands. But I really have never done a suprapubic tube. Any other questions? Well, thanks for your attention. These are always a little strange doing these lectures where I can't see the audience and see the interest and get the kind of the visual cues, but I hope you find this helpful. Again, I know you got some more lectures on this series about how to do hypospadias, but again, take the long view. There are a lot of talented people doing a lot of talented hypospadia surgeries, but when you get out there and do them yourselves, just take a good look at your repairs and make a commitment to look at your outcomes and stay abreast of the literature, go to meetings. Often I'll pick up new ways of doing things by watching the video, and the video may be about how they did this great tunica vaginalis flap or something like that, but I may learn of like, wow, look how they put those holding stitches in the penis, or they're sitting down. I do most of my repairs sitting down. I wasn't trained that way, but I watched videos and saw people doing that. So a lot you can learn once you get out in training. In fact, you're going to learn a whole lot more when you finish your training than you did during your training, which is a scary thought, but really all this training is just a license to learn. Hypospadias repair is a lot of fun, but it is humbling. Let's see, question here. What is your opinion about testosterone pre-op? It's controversial for sure. I've always been a believer in it. If I've got to make an 8 French tube, it's got to be 8 millimeters wide. And typically I want it to be 10, so it's got to be 10 millimeters wide. So if my plate's got to be 10 millimeters wide and their glands is only 10 or 12 millimeters wide, that's too hard to bring around that new urethra. So I believe in the data that says that you need that the complication rates are less when the gland's width is 13 or 14 millimeters. So I keep a ruler in my pocket. I take them from the operating room that aren't used, keep them in my pocket, clean them between clinic visits, but I measure the glands. It can be a little challenging, but I really want that. If the glands is less than 13 or 14 millimeters, I'm going to give testosterone because I think that you just can't get that glands closed well if you're going to get your urethra the proper size. That's my opinion. There are people that disagree. I think there's evidence to support either way. But again, for proximal repairs, you really don't need it. And I don't do weight-based. I use 25 milligrams and then see how they respond, and rarely do I increase that. This case we did today, he didn't respond well and needed higher doses. Again, if there are not any other questions, I appreciate your attention and hope you find this information helpful as you go through your training and in the early years of your in your career. But again, these kind of data are useful your entire career because I'm smarter. I can better talk to the teenagers who now I'm seeing who I repaired as infants. Thanks again for your attention. Everybody stay well. Oh, somebody said thank you, so you're welcome. Stay well. These are difficult times. I'm glad we're able to do some education together around the world, but everybody be safe out there. Thank you. Good night.